Good evening, everybody. We are waiting for people to complete to be entering. We would like to welcome you in GAED, the Gulf Association of Endocrinology and Diabetes. In our monthly webinar, this night we have thyroid cancer webinar. We have 3 lectures, and this is awarded CME by Health Authority, and we encourage all participants to fill their feedback after they finish. And if you have any question for all the speaker, you can put in question and answer. Today we have 2 bright stars, Professor Hossein Gharib from Mayo Clinic and Professor AlZahrani from King Faisal Specialist Hospital. And I will be chairing the session. I am glad to be here, Dr. Naji AlJohani from King Fahd Medical City. The first lecture will be presented by Dr. Hossein Gharib, which is non-surgical management of papillary thyroid microcarcinoma. Professor Gharib, he's well known to the area as well as international. He get his MD degree from the University of Michigan Medical School and completed internal medicine residency and fellowship in endocrinology from Mayo Clinic. He joined Mayo in 1972 and was promoted to professor in medicine in 1994. Dr. Gharib is the international authority in thyroid disorder. He published more than 200 papers in thyroid, in the field of the thyroid, and 3 endocrine books, including Thyroid Nodule in 2017. He is a worldwide famous international speaker, and he has more than 350 national and international endocrine events. He served as editorial board member of many journals, including GCM, Thyroid, Endocrine Practice, Acta Endocrinologica, and US Endocrinology. He is the recipient of many awards, including award from Endocrine Society, ATA, ACE, ACP, and her doctorate from Carla de Vella University from Medicine in Bucharest. He is past president of ACE and American College of Endocrinology as well as ATA. Welcome, Professor Gharib.
Thank you very much, Dr. Naji, and to all the participants, greetings from Mayo Clinic in Minnesota. A pleasure to participate in this webinar. The topic is medical management of papillary thyroid microcarcinoma. This topic and area is new, and it is also of intense interest and a matter of debate in current thyroid practice. So I have nothing to disclose, and I'd like to thank the organizers and GAED for the invitation to speak at this meeting. So you see a patient with papillary thyroid microcarcinoma. The question is, are you going to recommend active surveillance or observation and follow-up, or lobectomy? We will then discuss the criteria and the rationale and the results of a new approach to thyroid cancer. So when you want to decide what to do, you want to know which tumors are we talking about, which patients, what is the follow-up plan? What is the follow-up plan, and when do we then change course from observation to surgery? So treatment options for papillary thyroid microcarcinoma. One option is active surveillance, the subject of our discussion. Alternatively, current practice is thyroid lobectomy. So what I'm going to present to you is something that is not for every thyroid cancer, not for every patient, and it's not even for every clinician. You have to select what you want to offer to your patients. So papillary thyroid microcarcinoma, by definition, it's a small tumor, less than 1 centimeter. It is more and more commonly identified on imaging. Patients who have PET scan for unrelated thyroid disease, patients who go to emergency room with neck pain, ultrasound exam for discomfort in the neck that finds a tumor that is small and finally identified as papillary. This is almost always asymptomatic. In our practice, 50% of papillary cancers are microcarcinoma. So it is a significant proportion of patients. In general population, the prevalence of papillary microcarcinoma is somewhere around 10%, varies from 2% to 30%, which means that in the audience tonight of almost 500 or 600 participants, 10% of us have papillary thyroid cancer, which hopefully never will become biologically important. So what is the standard therapy? Currently, papillary thyroid microcarcinoma, we say lobectomy is adequate. We say that prophylactic neck dissection not recommend necessary. Radioiodine treatment not necessary. If you put patients on thyroxine post-op, TSH, complete TSH suppression not required. What is outcome? Outcome is recurrence less than 5% and mortality less than 1%. So we are talking about a disease that has excellent prognosis with minimal invasive treatment. So why should we delay surgery for papillary cancer? Well, look at the statistics. Mortality is very low, recurrence is low, and there is increased risk if the tumor is extend beyond the thyroid, or if it is molecularly aggressive, but those are rare exceptions. So outcome remains excellent. These are some data that quickly we look at here. You look at the recurrence rates, less than 5%, mortality less than 1% in most series. Of note also is the importance that anywhere up to 40% of tumors can be multifocal or nodal disease at diagnosis, maybe as much as 40%. So disease in almost a third to half of cases already is spread to lymph nodes at diagnosis. So let me give you a couple of examples of cases. This is an 82-year-old patient who is in good general health, screening neck ultrasound, discovered a thyroid nodule. Biopsy shows a 7 millimeter papillary thyroid cancer. He is in good health. What should we do for him? What now? Surgery or observation? Our next case is a 65-year-old man who has multiple comorbidities, including colon cancer with metastasis. He's a sick person, but he also has an 8 millimeter discovered papillary thyroid microcarcinoma. So the question is, what should we offer him? Surgery or observation? And then the third case is probably the most challenging. 27-year-old nurse. She wants to get married. She doesn't want a neck scar before surgery, before wedding. She wants to have wedding and then wait a few months, go to honeymoon. And then after that, she wants another time off to look for a job. Not interested in surgery. And so we want to plan on an approach that is acceptable to our patients, but also has good outcome. What does active surveillance mean? It is not watchful waiting. It is actively monitoring disease. So it's an active observation. We say surgery is deferred until necessary. Patients with known or highly suspected disease. So even if a patient has not had FNA proven papillary, but a highly suspicious by ultrasound nodule would qualify for this plan. As far as we know, therapeutic delay does not change outcome. We can always change course and operate and remove tumor. And what are classic examples? Non-thyroid would be small volume prostate cancer, urethral cancer, or some lymphomas that are followed without treatment. So the data originated from Japan, and this is one of those original studies by Dr. Miyachi and colleagues who had more than 2,000 patients with papillary thyroid microcarcinoma. 55% accepted medical observation. And in this group, you'll see that 92% followed for 10 years had no problems. They continued surveillance. Less than 10% required alternative management at some time during their follow-up. And when surgery was offered, it was equally effective as it had been at onset. So when this slide also shows from the same group that when patients with papillary thyroid microcarcinoma observed for 10 years, what happens? So you'll see here in the light blue, patients who are older than 60 years, that usually comprise most of our patients with papillary thyroid microcarcinoma. You'll see here that if patients are less than 60 years of age, less than 2% will show an increased size in 10 years. Less than 1% will have lymph nodes that are worrisome on follow-up or progression to clinical disease requiring action in less than 2%. So the vast majority of our patients, when they're older than 60, do well. So it would make sense to follow them conservatively. So what are the indications that you change course during follow-up? Basically, increase in size, 3 millimeter size, followed by careful ultrasound or volume increase. If you identify adenopathy that was not present before, if there is extension of tumor outside the capsule, or if the patient says, I'm tired of follow-up, I want surgery. Any of those then would be an indication for changing your management. So when we want to key factors in the clinical decision making at this point is that tumor size, was it changing? Volume size? What about the location of the tumor? Is the tumor now getting close to capsule? What about abnormal lymph nodes? Or what if the patient says, now I'm tired of follow-up, I want action? So those are the items that we consider during the periodic follow-up of our patient. The 2015 ATA guidelines suggest that if endocrinologists or physicians identify a small thyroid tumor, usually that follows with ultrasound exam, that follows with FNA, and once FNA is done and diagnosis is made, it is almost inevitable that the next step is surgery. But yet ATA guidelines recommend observation in cases where the tumor is very low risk, a patient is accepting follow-up, if the patient is of high surgical risk with a lot of comorbidities, or if the patient has a short lifespan, has metastatic malignancy, which is progressive. So under these conditions, the guidelines suggest that observation would be a good plan. Here is a patient with a nodule that is small, but has definite area, safe area around it. So this would be an ultrasound appearance of a nodule that is ideal for follow-up. On the other hand, this nodule, which is close to the capsule, even if it is 8 millimeter, 8 by 9 millimeter, it is not one that we would recommend follow-up. And in fact, this patient has surgery and had the tonsil variant of PTC with minor extrathyroidal extension. So we would not follow this patient, even though tumor is sub-centimeter. So how do we select patients? These are the criteria that are generally accepted. Tumor less than 1 centimeter, there is no extrathyroidal extension, no abnormal lymph nodes, no evidence of distant metastasis. It is ideal that there's only one nodule that is papillary cancer, but if there are multiple nodules and the other ones appear benign or very small, those would qualify as well. And then, of course, patient must understand and be willing to be followed. So observation seems to be a good plan. How do we do it? We follow these patients every 6 months for 2 years. We do palpation, we do ultrasound, and we measure TSH. And then during this time of follow-up, if there are indications for changing course and changing action, taking surgery as an alternative would be dictated by the enlargement of a nodule, either by diameter or volume, or the appearance of lymph nodes or other criteria we talked about. So this is another case of a 32-year-old patient who is planning pregnancy and has a small tumor, 8 millimeter papillary thyroid microcarcinoma. She wants to have more children. Pregnancy is in her near future plans. The question is, do we offer observation or surgery? And data show that young women who get pregnant often have an enlargement of thyroid, small thyroid tumors. And so because of these data, in this case, even though she seems to be qualified, we recommend not observation. We recommend surgery, and that's what we offer. So we say, let's have surgery and then follow with a plan for pregnancy. And then finally, the last couple of slides discuss the rationale for less surgery rather than more aggressive surgery. A 36-year-old woman who was incidentally found to have an asymptomatic thyroid nodule, TSH is normal. Ultrasound shows a 2 centimeter solitary mass in the thyroid. And biopsy was positive for papillary. So the question is, classic conventional approach would be total thyroidectomy, and the rationale for that is the data that suggests that multicentricity could be around 40%. But in current practice, we recommend lobectomy, especially the awareness in many patients that they want to avoid post-op thyroid hormone therapy. So we say, let's give them a chance and not do total thyroidectomy. So why should we recommend lobectomy for papillary microcarcinoma? Well, cause-specific mortality is less than 1%, which is very low. Distant metastasis, very low. And when you do more extensive surgery, that does not change outcome. Both outcomes are excellent. And then when you consider that most thyroid surgical procedures are done by general surgeons in small community hospitals, complications add up even when they are done with apparent, quote, expert surgeons. So more surgery, more extensive surgery, more likely complications. So with lobectomy, less likely complications. So we favor lobectomy for small thyroid tumors. So lobectomy is sufficient if tumor is a small, low-risk tumor. It is a unilateral nodule. It is inside the thyroid with no lymph nodes and no radiation history. Lobectomy would seem to be a sufficient procedure for these patients. So what about the objection that some of you have to follow up? Well, it makes it, lobectomy is difficult to follow in a patient because serum Tg is never zero. So this is a reasonable plan for follow-up. We consider TSH of less than 2.5 optimal. Therefore, we follow these patients without thyroxine therapy, only starting thyroxine if TSH is beyond 2.5. We bring the patient back in 6 to 12 months for follow-up. We measure TSH, Tg, and also ultrasound. And then we know that Tg will be detectable because they had lobectomy, not total thyroidectomy. So the number of Tg is not, the absolute number is not significant, but the trend is. If Tg is 7 and stays around 7 in follow-up, long-term follow-up, then that is clinically insignificant. If that number of 7 then increases to 17 or 25, then obviously more tests would be required. And so the imaging is something that we do for regularly for several years, and then less so after 5 years. And then obviously, if we decide on completion thyroidectomy, that would depend on whether or not there is some evidence that disease has come back, or there is in the other lobe, or lymph nodes have come back, or other indications. In addition to observation as an alternative to surgical intervention, currently a number of centers, including ours, we are treating patients with papillary thyroid microcarcinoma with percutaneous alcohol ethanol injection. Some centers are doing RFA for small thyroid tumors. So there are alternatives to extensive surgical treatment, and these are gaining fairly wide interest and acceptance, mostly in Europe, but also in the US and probably in your area. Laser treatment is something that has been done successfully for small thyroid tumors or cervical adenopathy. Microwave ablation is still experimental. So in conclusion, then, observation, which is active surveillance, is an accepted and, in my opinion, a desirable option for papillary thyroid microcarcinoma. You can discuss it with your patient and offer an outline for follow-up and see if she or he accepts this. Specific characteristics must be met when you want to make this recommendation to a patient. Risks are low, and in patients, especially those who are older, it seems to be a very reasonable proposal. And then, of course, follow-up plan is one that we discussed, how you follow these patients long-term. And non-surgical treatment for papillary thyroid microcarcinoma includes alcohol ablation or RFA, and these are gaining rather wide attention and probably will be discussed in various meetings and studies in the next few years. Lobectomy for small thyroid tumors is accepted, and total thyroidectomy or radioiodine ablation, etc., not necessary for low-risk papillary thyroid cancers. And the hope is that we do less aggressive management for tumors that are not very aggressive and have good outcome. And thank you very much for your attention.
Thanks, Dr. Gharib. Excellent presentation, and we will keep the question at the end. And now we'll move to the second speaker, Professor Ali AlZahrani. His talk is Individualized Approach of Thyroid Cancer Management. Professor AlZahrani is a consultant endocrinologist and at King Faisal Medical Specialist Hospital and Research Center, and Professor of Medicine and Endocrinology in Al Faisal University. He is also recipient of International Clinician Award of ACE 2016. He was editor-in-chief of Annals of Saudi Medicine. He is an editorial board member of Official Journal of ATA, Thyroid, and academic editor of PLOS One journal. Dr. AlZahrani has published more than 120 peer-reviewed articles and give more than 200 regional and international presentations. His academic interests are clinical and molecular research in the area of thyroid cancer and endocrine genetics. Welcome, Dr. Ali.
Thank you very much, Dr. Naji, for the nice introduction, and thank you for GAED and the organizing committee of this activity. I feel very privileged, honored, and humbled actually to participate in this symposium with what I would say two internationally renowned professors, Professor Hossein Gharib and Professor Gharib, Hossein. It is really a special honor for me to be with my friend, Dr. Gharib, who has supported me and supported many, many people in the Gulf and across the world in their career. And he has been always a wonderful person, a giving person. I could actually spend the rest of my time talking about Professor Gharib for his kindness, support, professionalism, but I will stop there and again take a great pride of being with him tonight talking about thyroid cancer. All right, so the subject is thyroid cancer risk-based management. I have nothing to disclose. I think we all know, and Dr. Gharib already mentioned this, that thyroid cancer has been dramatically increasing over the last 4 decades. This data is from SEER data in the United States, so you can see that the incidence has increased significantly over the last 3-4 decades, with numbers from around 4 to 5 per 100,000 per year. Today, we are looking at numbers around 20 per 100,000 per year. As mentioned, and this is very important information, again, this is data from USA. Dr. Gharib mentioned that around 50% of those tumors are less than 1 centimeter. You can see between 1 to 2 centimeters, there is also an increase, but it's not as steep as the microcarcinomas. Tumors larger than 2 centimeters, up to 5 centimeters, has increased slightly, and tumors more than 5 centimeters remain stable for the last 2-3 decades. So it's clear that this increase in incidence is mostly in small tumors, whether that's a real increase or because of better detection of the disease with the high technology that we have today, specifically NIC ultrasonography, is not completely resolved. Now, as mentioned, around 50% less than 1 centimeter and around almost 90% less than 2 centimeters. So we're dealing with a disease that for the most part is a small and low risk. Let's look at some local data. This is from Saudi Arabia. The most common cancer in Saudi Arabia is breast, colon, and thyroid comes number 3. So this is very common disease. When you look at it by male and female, you can see that it is the second most common cancer after breast cancer, and it's number 8 in men. And the data from the rest of the Gulf countries are the same. I don't have time to cover all, but more or less similar data. This data is from our hospital, which King Faisal Specialist Hospital Research Center in Riyadh, which used to be more or less the only center dealing with thyroid cancer until around 10-15 years ago, where we have now many other centers dealing with thyroid cancer. So if you look at this data, although it's an institutional data, it represents to a great extent the data at a national level. And you can see thyroid cancer has been increasing year after year Of course, there is expansion of the population, there is easier travel, etc., but I think it is reminiscent of what we have seen in data in the United States and other parts of the world. Because of this, I think it was also important for us to look at our own data on thyroid cancer to see if this is different from the international data. And this is a study in which we looked at around 600 patients 2 years ago. What we found is that the median age is around 39 years. If you look at the data from the United States, it's 51 years. So our patients tend to have thyroid cancer around a decade earlier. Male to female ratio is the same, around 1 to 3. Tumor size, again, is small. The median tumor size is around 2.1, and you can see the range here. But there are some features that seem to be more frequent in our population. Tumor multifocality is 51%, extrathyroidal extension 42%, lymphovascular invasion, which is not a very good feature, is around 37%. And then when you look at the lymph node metastasis, 60% of our patients have lymph node metastasis. More striking is the fact that many patients at the initial presentation, which is unusual, present with distant metastasis, so 13%. I think when you look at other series, it's in the range of 4 to 5. So there seems to be some indication that the disease in our region is more aggressive, presenting earlier, more multifocal, more histopathological, aggressive histopathological features, distant, and lymph node metastasis. When you look at the tumor type or subtypes, most of our patients, similar to others, 77% is conventional papillary thyroid cancer. Follicular variant papillary thyroid cancer comes next. Follicular thyroid carcinoma, only around 5%, and then other types, the tall cell, the columnar cell, the diffuse sclerosing, and others. Looking at the TNM staging, and at that time, 2017, we had TNM7 staging, but again, it is representative of the situation. So you can see 70% are in stage 1. And the reason for this is most of our patients are young. As I mentioned, the median age is around 39. And as you probably remember, TNM7 divide age into less than 45 and 45 and above. So most of our patients are young, although they may have aggressive disease, but because of their age, most of them in stage 1. But we have around 30% in stage 2, 9%. The higher stages, stage 3 and 4, you can see 11%, 2%, 1%, 8%. So roughly 22, 23% are having a high stage disease. So let me conclude this part because it sets the stage for the next part. So I think from Professor Gharib's talk and this introduction, it's clear that differentiated thyroid carcinoma is very common and is increasing in incidence. Most cases have small tumors at low stage, and they carry small risk for mortality. Around 10 to 15%, maybe in our population up to 20%, are high grade and carry significant risk of recurrence and mortality. So I think the art of practice and approach to thyroid cancer is that we need really to filter out high risk from low risk. So while we don't want to be aggressive with patients like the ones described by Professor Gharib, we don't want to miss the 20%, 15, 20% who are high risk, because those are the ones who come to us with metastasis, morbidity, and they die. Mortality is not very uncommon. We see patients on a regular basis who come with brain metastasis, skeletal metastasis, lots of morbidity and mortality. So we should not, in the middle of this conservative approach, we should not forget this small percentage of patients who have high risk. So I think that's the whole thing is can be dealt with by risk stratification. And this is the subject of this lecture. So what is risk stratification? We will talk about this, and I think it has become now more or less a standard of care for most people in the United States and outside to use the ATA guidelines as a standard of care for patients with thyroid cancer. I like two statements at the beginning of the guidelines, and I think it's worth reviewing. The first one is really emphasizing what I just mentioned. A major goal of these guidelines is to minimize potential harm from over-treatment in the majority of patients at low risk for disease-specific mortality and morbidity, while, and this is very important, while appropriately treating and managing those patients at high risk. So I think this is a kind of declaration that we should keep in mind. We do not want to over-treat low-risk patients. We want to appropriately treat and manage high-risk patients. Second thing, and I think this is extremely important because I hear people in our rounds, meetings saying the guidelines said this. These guidelines should not be interpreted as a replacement for clinical judgment and should be used to complement informed, shared patient healthcare provider deliberation in complex cases. I think this is also very important. The guidelines are just guidelines. They guide you to plan for your patient, but they don't replace your brain and skills. So this slide is actually from Dr. Tuttle, again, showing what has happened in the last 10 to 11 years. We had, prior to this, although many people, I remember that very well, many people were talking about the fact that we should not treat the patients equally. One size does not fit all, but it was the case actually before around 2010. We used to do total thyroidectomy or near total thyroidectomy for the majority of patients, give radioactive iodine for the majority of patients, and then we put them on thyroid hormone suppression and we follow them in the same way. What has changed is what is called risk-adapted paradigm management. So that management recommendation is based on the risk. If you have a high risk, treat aggressively and proactively. If you have low risk, just be conservative. So there is an increased emphasis on assessing risk and predicting outcome, and there is rapid movement toward a more minimalistic management approach. In other words, minimal intervention. But that's again for patients who are low risk. I had also the pleasure to spend a couple of months with Dr. Tuttle in New York, and during this time, we wrote this review article on risk stratification in thyroid cancer, and I think it's a nice article. The way we designed it is this way, that risk is a continuous process. It starts from the moment you see the patient, even before diagnosis, when the patient presents with a nodule. So when he presents with a nodule, you assess the risk of malignancy. You assess the risk of malignancy and decide whether to pursue FNA and other diagnostic test or not. When you diagnose the patient again, you decide whether this is a high risk, whether this is a very small risk that can be followed up without intervention, and then we'll see the rest of the story. So there are at least 3 stages for thyroid cancer when risk stratification is very critical. One is here at the diagnostic stage. When a patient presents with nodule, you need actually to decide first whether you want to do FNA or not, depending on the size and the ultrasonographic features. And then if you do FNA and it turns out to be thyroid cancer, you would have to decide whether it can be followed without intervention. And I want to emphasize what Dr. Gharib mentioned, that not everybody can follow those patients, and not every patient can follow a surveillance method, and not every center. So if you have, they have basically the essentials of all of this, and you have the knowledge and experience, it might be possible, especially for microcarcinoma, to be followed and without intervention until some signs of aggressiveness shows up. The second thing here in this stage is to decide whether to do lobectomy or total thyroidectomy, or to do lymph node dissection or no lymph node dissection. So this is all risk assessment. Now the patient goes for surgery, he comes to you around 6 to 8 weeks. Now we have another chance to assess his risk. And now we have a lot of information from the pathology and radiology. And now here we use another method. We use TNM staging to predict basically mortality. And we use ATA risk stratification to predict whether the risk of recurrence. So this is another stage or another step in this journey when you can assess the risk of mortality and risk of recurrence and decide based on that how aggressive you want to move. For example, whether to give the patient radioactive iodine or not, how frequent you will see this patient, and so on and so forth. Finally, and this is something that is credited to Dr. Tuttle in over the last decade, is really every time the patient comes to you for a visit, for evaluation, you have another tool to decide to assess the risk. And this tool is what is called response to therapy status or dynamic risk stratification. So a patient who might be high risk at this stage, during the follow-up after treatment, he may turn out to be actually low risk, being in excellent response or being in indeterminate response. On the other hand, he could be a high risk because he already has structurally incomplete or biochemically incomplete response. So you can see that this is a continuous process. Risk stratification is the key for good management and appropriate management of patients with thyroid cancer. It's a dynamic, iterative, and active process, and we have different tools at different times. We have static tools like TNM and ATA risk stratification after surgery, and we have dynamic tool like response to therapy or dynamic risk stratification. Okay, so talking about surgery again, and this is from the guidelines, what type of surgery? This is a risk assessment. If the risk is low, we just need lobectomy. If the risk is high, you need total thyroidectomy. These are recommendations from the ATA guidelines, and I think they are very valid, common sense, and very useful. So near total or total thyroidectomy obviously should be done for patients with high risk, and those are patients with large tumors, gross extrathyroidal extension, or if they already have lymph node or distant metastasis. This, I think, it's even common sense recommendation, and these are strong recommendations with moderate quality evidence. What about if you have a patient who has intermediate features? Then you have the option of doing either near total or total thyroidectomy on one hand, or unilateral lobectomy. So who are the patients who are candidate for this type of treatment, for either of them? Tumors between 1 to 4 centimeters, and this is, all of these conditions have to be met. No extrathyroidal extension, and no lymph node or distant metastasis. Those patients, if you have a patient with 2 centimeters or even 3 centimeters, completely intrathyroidal, there is no extrathyroidal extension and no lymph node metastasis based on ultrasound and examination, and no indication that the patient had distant metastasis, then it all depends on how you practice in general, where you practice. If you are one of the conservative people, you would definitely will send this patient for unilateral lobectomy. If you tend to be more aggressive or working in an environment where we tend to do more for those patients, then near total or total thyroidectomy will be done. And either of them is acceptable. And it has to be also based on other patients' characteristics. Now, thyroid lobectomy alone is sufficient for low-risk papillary or follicular thyroid cancer. However, as mentioned here, this is a qualifying statement. They give you the chance to decide based on your practice and your feeling. However, the treatment team may choose total thyroidectomy to enable radioactive iodine therapy or to enhance follow-up based upon disease features and patient preferences. So I think this is kind of middle zone, gray area, but it is very acceptable either way. What about patients who should go only for lobectomy? You should not send them for total thyroidectomy. I think Dr. Gharib elegantly described them. Patients with small tumors, I don't think any patient with less than 1 centimeter who has no distant or lymph node metastasis, no other aggressive feature, should go for more than lobectomy if we don't even choose surveillance. Small unifocal intrathyroidal carcinoma in the absence of prior head and neck irradiation, familial thyroid cancer, or clinically detectable cervical lymph node metastasis should only have thyroid lobectomy at most. So now we send the patient for surgery. We did surgery based on the features, whether it is total thyroidectomy, whether it is lobectomy. He comes to you 6 to 8 weeks later, and now you need again another round of risk stratification, but this time we are using more standardized tools, the TNM 8th edition and the ATA. The TNM predicts death, mortality, while ATA predicts recurrence of the disease. Now, I've just mentioned this, that ATA in general predict recurrence, and TNM AGCC predict risk of death. This is again from the guidelines, and they classify patients. The ATA classification for risk of recurrence is put in 3 categories: high risk, intermediate risk, and low risk. And you can see this, the low risk is completely intrathyroidal. They allowed in this version of the guidelines up to 5 lymph nodes, but they should be less than 2 millimeter. The high risk, as described here, gross extrathyroid extension, incomplete tumor resection, distant metastasis, or lymph node that are larger than 3 centimeters. Anything in between goes into the intermediate risk, either aggressive histology, minor extrathyroidal extension, vascular invasion, or more than 5 lymph node metastasis. But they actually emphasize that risk of recurrence is a continuous process. In fact, they were going to cancel this, but they kept it to keep a standardized way of talking between researchers and clinicians. But you can see here on one side, on the lower side, unifocal papillary microcarcinoma, the one described by Dr. Gharib. The risk of recurrence is only 1 to 2%. On the other hand, if you have follicular thyroid carcinoma with extensive vascular invasion, the risk is around 30 to 55%. And in between, you can see the features. So when you have your patient in the clinic, if you have this diagram, for example, you could even predict what risk of recurrence this patient has, and based on that, decide what is the next step in the management. TNM is predict mortality, and it is a bit complex, especially for patients more than 55 years. This algorithm is relatively simple if you keep it. So if you have a patient less than 55 and he does not have distant metastasis, he's going to be stage 1 no matter what. If he has distant metastasis, he's going to be stage 2, and that's it. When he is 55 and more, maybe the first thing you should look for is distant metastasis. If he has that, he's immediately in stage 4B. If he doesn't have it, look for gross extrathyroidal extension. If it is there, limited to strap muscle, stage 2, subcutaneous larynx, subcutaneous tissue, larynx, trachea, esophagus, stage 3, and brief vertebral fascia or encasing major vessels is going to be stage 4A. If there is no gross extrathyroidal extension, the tumor is small, no lymph node metastasis, is going to be stage 1. If it is larger than 4 centimeters or there's lymph node metastasis, going to be stage 2. You don't have to memorize this. You can always keep it in your clinic, and with practice, it will be automatic. Now, we looked at this TNM staging system in our population because we cannot always use the Western data and believe that they will be applicable to ours. So this is actually a study that we just published last year with the title of How Does TNM Staging System 8th edition perform in comparison to the 7th edition in our hospital. So we studied 700 patients seen during a 3-year period, that's 2004-2007. We choose this to have a good follow-up on those patients. And you can see that in green is the TNM8 and in blue is TNM7. You can see that TNM8 downstage many patients who were in higher stage in TNM7. So you can see we have more patients. They are the same patients, but we have more patients in stage 1, in TNM8, in stage 2, less patients in stage 3 and 4. So in general, and this is not only us, also from many other series across the world, TNM8 downstage many patients to lower stages compared to TNM7. So, and I think part of that is the change in age, but there are also other things that were considered. For example, minimal extrathyroidal extension and lymph node metastasis are less considered in TNM8, or considered less aggressive in TNM8. You can see here the changes more. Essentially, this is TNM7, this is TNM8. So there's a lot of downstaging from higher grade in TNM7 to lower TNM8. And when we looked at the Kaplan-Meier performance in TNM7 versus 8, TNM8 was much better performing, separating patients with stage 1, stage 2, stage 3. While if you look here at TNM7, you can see there's a lot of mix of lower stages. Only stage 4 separated well, but stage 1, 2, 3 did not. This is for disease-free survival, and the same thing for cancer-specific survival. TNM8 did perform better than TNM7 in predicting cancer-specific survival over time. Going back again to the risk stratification, we said in the post-operative period, we use these two staging system, and the ATA staging system is again very useful for prescribing radioactive iodine or not. Now, when should we give radioactive iodine? I think we all agree by this time that low-risk patients, especially microcarcinoma, should not receive radioactive iodine. In fact, they should not receive even total thyroidectomy. So you're not going to give radioactive iodine anyway. So patients with lower ATA low risk, less than 1 centimeter, unifocal or multifocal, the recommendation is not to give them radioactive iodine, even if you do total thyroidectomy. Patients in low risk, and that include T1B, which is 1 to 2 centimeter, or even T2, which is between 2 to 4 centimeter, but no other features of aggressiveness. No lymph node metastasis, no distant metastasis. You may not give them radioactive iodine. They leave it for you here a little bit flexible, but in general, we don't give those patients radioactive iodine. What about patients who should receive radioactive iodine? Those are the ones here, the high-risk patients. T4 tumor more than 4 centimeter, regardless of the lymph nodes, or patients with metastasis already. I think there's no question that those patients should receive radioactive iodine if they have distant metastasis, or if they are T4, which means basically they have gross extrathyroidal extension. I think the controversy and the difficulty is in this group, the low to intermediate risk. For example, patients with tumor more than 4 centimeter, with microscopic extrathyroidal extension, patients with central compartment lymph node, patients with lateral compartment lymph node, and you can see that the indication is increasing. So the more aggressive feature, the more indication to give radioactive iodine. And again, the practice is different between different centers. I guess at Mayo Clinic, they are a bit conservative when it comes to radioactive iodine. The same at Siloam Memorial Hospital. In other places, they give radioactive iodine more liberally, especially outside the United States. Okay. Because this is a very complicated area, the intermediate and the low risk, we decided to look at this in a recent, again, work. So we looked at the course and predictive factors of incomplete response to therapy. In other words, patients who have biochemically incomplete or structurally incomplete. What is the course in those patients who have low and intermediate risk thyroid cancer? So first of all, low risk separated nicely from intermediate risk. All of those patients, 506 patients, they are all low and intermediate risk. We did not include, we excluded actually high risk patients. So you can see the ATA risk staging system works beautifully here, separating the two groups. Then we looked at what are the predictive factors of incomplete response. And you can see here, excellent response versus incomplete response. We found two factors. One is age, and the other one is lymph node metastasis. We did not find a correlation between tumor size, sex, multifocality, even lymphovascular invasion, but we had a small number of patients. Even radioactive iodine did not make a difference, another intervention. Now, when we focused on the age and lymph node metastasis, we found some interesting information. So again, the summary of this slide is that age and lymph node metastasis were predictive of incomplete response, biochemically incomplete or structurally incomplete. When we looked at age as a risk factor, we actually defined patients based on their age, 25 years, 28, 29, and so on. You can see here the p-value was insignificant. And then by the age 30, we start to see borderline significance. And as the age increases, the significance increases. So what we concluded from this is that age is a continuous risk factor. The idea, and this is not only us, other people found that age is not really a categorical factor. It is a continuous factor. And in our series of 500 patients, we found age more than 33 years is significantly associated with incomplete response in the low to intermediate group, ATA group. When we looked at the lymph node metastasis as a predictor of incomplete response, it was also very interesting that central lymph node did not correlate with incomplete response. It is actually the lateral lymph nodes. So if you have jugular lymph node in the lateral compartment, this is a risk factor for recurrence in the low to intermediate risk. Of course, if you have lateral and central, still it's significant, and the significance is most likely due to the lateral. So again, only lateral or lateral plus central lymph node metastases were predictive of incomplete response in low and intermediate risk DTC. Only central lymph node was not predictive of incomplete response. Final thing here is the patient is treated. Now you're following him year after year, and you're using the dynamic risk stratification of what's called response to therapy status. And this classifies patient into excellent, biochemically incomplete, structurally incomplete, or indeterminate. So let's look at this. I think just as a matter of definition, you all know it. Excellent response means the patient has no clinical, biochemical, or structural evidence of a disease. This is, again, a slide from Dr. Tuttle. Biochemical incomplete response is when the thyroglobulin is elevated or Tg antibody is increasing in the absence of localizable disease. Structurally incomplete is basically when the patient has anatomically well-defined recurrence, either by FNA or CT scan or PET scan. An indeterminate response are those patients who have slight elevation in thyroglobulin or a slight elevation of Tg antibody. So you're not confidently sure whether they are free of the disease or having the disease. So how does this system work long-term? Does it predict the outcome? The answer is yes. This is probably one of the earliest studies that looked at this, and this is a summary. If you have a patient with excellent response, no evidence of disease is basically the case in 96%. Only around 4% will have recurrence. If you have a patient with indeterminate response, 87% will have no evidence of disease, and around 10% will have, or less than 10% actually will have persistent biochemical disease. As you move to biochemically incomplete, you see less cure or less absence of a disease, more biochemically incomplete, and more now you start to see structurally incomplete. And as you go to structurally incomplete, obviously most of a good percentage of them will have structurally incomplete. They are at risk also of death, and only a minority will be cured. So I think if we are to invest in the care of thyroid cancer patients, these two categories are the culprits. They are the ones who tend to have morbidity and mortality. Those who are in excellent response or even indeterminate response, they will do fine over time. We looked at this also in our population. So this is again a recent article on natural course of the American Thyroid Association response to therapy status, which is called also dynamic risk stratification in differentiated thyroid cancer. What we did, this is a complex diagram, but I will simplify it. So we started with around 800 patients. We exclude patients who have medullary or anaplastic or poorly differentiated or did not receive radioactive iodine. We ended up with around 500 patients who had total thyroidectomy or near total, plus minus lymph node dissection and iodine ablation. So all of them received iodine after good surgery. And this used to be the standard of care. What happens after this therapy for 500 patients? 52% at 6 to 12 months were in excellent response. 25 had indeterminate response. 6% had biochemically incomplete, and 16% had structurally incomplete. So what happens over time? And over time here, we're talking about 8 years. Some of them needed additional intervention here, 114 only. The majority did not need intervention, but many of them spontaneously, especially this group of indeterminate response, they over time converted to excellent response. They remained in excellent response. So you see the outcome over time was excellent. Actually, most of them were in excellent. 83% had excellent response versus 52 in the initial stage. 1%, the 25% indeterminate decreased to 1%. The 6.4% biochemically incomplete decreased to 3.6%, and the 16.2% structurally incomplete went down to 12.2%. But those are the ones who died, those are the ones who suffered. And again, you can see the response to therapy correlate or predict nicely the outcome over time. So you can see excellent response remains good. Indeterminate remains good for the most part. Biochemically incomplete, more likely to have disease, and obviously structurally incomplete response did not do well. I will skip this just for the sake of time. So based on all of this, this is again a slide from Dr. Tettel, and I think Dr. Gharib already explained it in the low-risk patients. If you have a patient with excellent response, you don't have to worry. They will do well. Even if their initial features are high risk, the expected outcome is that they will do fine. 96, 97% will not have a disease anymore. The risk of recurrence is only around 1 to 4%, and the risk of death is minimal. So you don't have to intensively follow those patients and aggressively investigate them. And you don't have to suppress the TSH very low. You can just aim for 0.5 to 2.5. If you have biochemically incomplete, the risk is around 30% will spontaneously resolve. The risk of structural disease is 20%, but their risk of death is low. And you can be more careful about their follow-up, but you don't have to be so aggressive. Structurally incomplete is really where the problems happen. So 50 to 85% will have persistent disease despite additional treatment, like our series that I showed you, and nearly all deaths happen in this group, structurally incomplete. So this is the group that we have to focus on. Indeterminate is really low-risk group. In fact, in our series, not even 5% had structural disease. Maybe around 1 to 2% had structural disease, and the risk of death is very low. And again, those group needs very conservative follow-up. So to conclude, I think we all agree that differentiated thyroid cancer is increasing significantly in incidence over the last 5 decades. Most cases are low risk for recurrence and mortality, but a significant portion can be of high risk, causing morbidity and mortality. In our series, around 20%, in other series, around 10 to 15%. The contemporary approach to management is based on risk assessment. So risk assessment is very vital for the care of thyroid cancer at this era. Risk assessment is a dynamic process. It's not one way to do it. It depends on what stage you are seeing the patients. If you're seeing the patient initially, then you have to decide what type of surgery. Most of the time we use ultrasound and the other features of the patient. If you're seeing the patient in the follow-up, then you use ATA and TNM staging. And if you're seeing the patient year after year, you use the dynamic risk stratification. If you have low-risk patient, the minimalist approach is the way to go. If you have high-risk patient, you should be proactive and aggressive in your approach. I think the problem is with the intermediate risk patients. Individualize your care based on the level of risk and be ready to change your strategy based on the changes in the patient features, using generally the dynamic risk stratification and your clinical judgment. Now with that, I'll stop. Thank you very much.
Okay, thanks, Professor Ali, for excellent presentation. And we'll move to the last presentation for tonight with Professor Gharib. Recurrent thyroid cancer, how to detect and when to treat. And after that, we have reviewing all the questions for both Prof. Ali and Prof. Hossein Gharib. Welcome again, Dr. Gharib.
Thank you very much. And as I am trying to get my slides in order, I want to say, Dr. Ali, what a great talk, comprehensive and so clear. I used to think of Dr. AlZahrani as a rising star in endocrinology. Now I know he is a shining star.
Just a reminder for all attendees for filling the feedback evaluation and the certificate by Dubai Health Authority CME will be awarded, and it will be sent to you by your email, registered email from the Gulf countries within 3 weeks. And you can add your question in question and answer bottom after this last lecture.
Once again, Dr. Ali, thank you for your presentation. And the previous one that I gave and Dr. Ali's and this one kind of is a continuum of current thoughts on thyroid cancer management and treatment. And I think that you'll enjoy this presentation hopefully as well. Again, thank you and no disclosures. So here are facts about thyroid cancer. As Dr. Ali so nicely elucidated, the incidence increases. It is mostly papillary. It's mostly small papillary cancers. And it is mostly low to intermediate risk cancers. And so the trend in current thyroid practice is less is more, less aggressive therapy. As Dr. Ali said, a strategy which is risk-based. So we are talking about how to detect and how to treat recurrent cancer. So let's talk about the modalities for diagnosis. Many of you still use your fingers. Thank you. Many of you order chest X-ray. That's useful. Some will order a radioactive iodine. Thyroglobulin is adding to our diagnostic test and sensitivity and accuracy. And then, of course, ultrasound, very sensitive and sometimes too sensitive. And then now PET scanning. So the result has been a wide variety of sensitive tests that may lead to identification of disease and management. So what is the consequence of discovering the disease? The consequence is management, approach, surgery, treatment. The first thing you want to remember is that what we say recurrence is not necessarily recurrence. It is likely persistent. We are talking about disease that comes back within 1 to 2 years after initial diagnosis and management. This is more persistent disease rather than recurrent disease. And the second point that you want to remember is that as we do more testing, particularly imaging and particularly ultrasound, as we do this, more of this, what happens is that we do more of this, which means we do more treatment, surgical treatment, radioiodine treatment. We find disease, we treat. We find disease, we treat. So that's where our practice has led to. Applying tests, identifying disease, and then proceeding with more treatment. What are the lessons that we have learned in the past several decades? The treatment has sometimes benefited patients. Most of the time, radioiodine has failed to eradicate disease. Most patients has persistent disease even after repeated neck surgeries and radioiodine treatment. There is no clear evidence of improved disease-free survival in the studies that have been published. And there seems to be a small incidence of clinically significant side effects from the treatments. Patients have repeated neck surgeries, radioiodine, complications. And all of these leads to increased patient anxiety and cost. Not only this, but also from your perspective, physician anxiety and stress. What to do for this patient, how to detect it, how to treat this little one. So let's see, where are we and what are we doing? So what are the tools in thyroid cancer surveillance? We have thyroglobulin, ultrasound, radioiodine scan, and PET. We'll cover these each very briefly. Thyroglobulin, not all tumors produce thyroglobulin. Differentiated thyroid cancer that typically secretes thyroglobulin may cease at the end because of dedifferentiation, and then will not trap radioiodine, so cannot be treated. If you measure thyroglobulin, try to use the same assay long term. Always ask for Tg antibody to be reported to you as well as TSH when you have a Tg measurement. And remember that we don't have a normal range for post-thyroidectomy Tg level. There are two ways to measure Tg. One is radioimmunoassay, and the other one more common is the immunometric assay. The immunometric assay, more common use nowadays. It is very sensitive, and it is susceptible to the presence of antibodies. Radioimmunoassay was a little bit more resistant to antibodies. Tg antibodies are a problem in our practice. We see them often in patients post-op. 30% of our patients have positive antibodies. Fortunately, in almost more than half, these antibodies decline and disappear after 1 to 2 years. So we are usually patient, just follow these patients. Tg that is less than 1% in post-op measurement after thyroidectomy occurs in 96%. So thyroidectomy alone can lead to no Tg post-op if there is no disease. If there is Tg antibody, what do? We send the specimen for mass spectrometry because that overcomes the Tg antibody. But mass spec is not as sensitive as Tg assay itself. So what is the value of Tg in a patient post-op 6 months? So you have a patient who had thyroidectomy, and then this patient comes to see you 6 months later, and you do a Tg measurement. Here is Tg that is undetectable or Tg that is greater than 10 at that 6 months level. So here, if Tg is less than 1 in 6 months, there's a 99% chance that that Tg will remain undetectable long term. If it is 5 to 10 at that time, at 6 months post-op, there's a 20% chance that there will be a it's the same Tg level in follow-up, which means that many of these patients will have show recurrent disease. So one Tg measurement post-op will give you a lot of useful information for long-term follow-up. What is the clinical utility of post-op Tg? Is that suppressed Tg of less than 1, as I mentioned, is associated with excellent outcome. So we ask our patients to come back 3 to 6 months post-op, we measure Tg, and if it is 0.1, which our lab reports, I'm very happy. And I tell the patient, you'll do okay. Suppressed or stimulated Tg of greater than 10 at that post-op visit, usually not a good sign. You know this patient is going to do bad. Recurrent disease, aggressive disease, metastasis, or even death. So that is a bad sign for follow-up. In some patients, serum Tg levels may decline even without further treatment. So if I see a patient who comes to see me 6 months post-op with a Tg of 2 or 3, I don't do much. I just wait. Maybe this Tg will gradually decline. So we are patient with these Tg reports. And then in patients that have detectable but stable Tg and negative imaging, we usually follow up with our treatment. So Tg positive, scan negative, we follow these patients. Try not to be aggressive, especially if you can demonstrate disease, they ain't going to die. What about ultrasound for follow-up? Well, ultrasound evaluation has become part of our management. Almost everybody now uses it, pre-op and post-op. Ultrasound is sensitive, but it is uniquely operator dependent. So some of you do it better than others, and you have gained experience, and you are very good at it. Ultrasound is widely available and is now affordable. Almost all physicians dealing with thyroid or thyroid cancer have one machine in their office. Ultrasound is better than CT or other imaging. It allows identification, accurate evaluation, and also biopsy. You can do biopsy. And we reserve other tests, WBCS, to scan or PET for special occasions. The study showed that ultrasound is the most sensitive test for follow-up. Next to that is Tg. Next to that is Tg level that is detectable. And finally, radioiodine scan. In that order of sensitivity and utility for follow-up. So in patients, there are two problems that we see in patients that are post-op in detecting persistent or recurrent thyroid cancer. Two problems. Problem one is we do ultrasound and we find thyroid bed nodules. Thyroid bed nodules, and these nodules are often tiny, multiple, less than 1 centimeter. The significance of these, we don't really know. Sometimes they can progress to clinical significant recurrence. But we follow these, especially if they're small, and you see here that most of these do not change. So thyroid bed nodules can occur, they're common, they're small, and best followed. Post-op ultrasound evaluation looks at thyroid bed and at lymph nodes. And when we do see a lymph node that is suspicious, we submit the specimen for cytology and for Tg. So we do two things. We want to make sure this is, if it is cancer, because sometimes cytology is indeterminate. It's not helpful, but Tg is. And the beauty of Tg in that specimen is that even if the patient has Tg antibody in the serum, you can still measure Tg in the specimen aspirated from the lymph node, and that is reliable. So what about lymph nodes? We often see lymph nodes in patients that are post-op, and these lymph nodes are often stable, and they don't change all that much when you follow them, especially in patients that have low-risk tumors. So the presence of lymph nodes in the neck post-op in patients with PTC, not always very bad sign. So what happens is in the case of a patient that has a lymph node and stable 5 years. Second patient, diagnosed lymph node confirmed by FNA, stable after 9 years. Patient number 3, suspicious lymph node, biopsy followed for 10 years without change. So in some cases, these lymph nodes don't change. They don't cause problems. They don't cause symptoms. We are happy if they are there and they don't change. So what happens if we find a patient with 1 or 2 lymph nodes that are positive for papillary, 3 years, 8 years, 12 years after initial treatment and diagnosis? When we see them here and we make a diagnosis, we biopsy, and if it is confirmed that this is cancer, we proceed with percutaneous alcohol injection. There is a rule at Mayo that we usually drink alcohol, but in these cases, we inject alcohol into the lesion. So we inject and results are excellent. We have had several hundred patients that we have treated through the past 25 years with good outcome. This is a recent patient that I saw. A large lymph node, proven, biopsy proven papillary recurrence. This is several months later, 75% reduction in volume and avascular. I follow these patients like this. When they are avascular, these lumps may stay, but they have no vascularity, and sometimes they even disappear over time, and it is a happy ending for patients who have recurrent cancer. So what about radioiodine as a tool for diagnosis and treatment? Well, the limitations is that there is some morbidity. We used to withdraw patients from thyroid hormone. Now we don't do that. Now we do with recombinant TSH. But it is expensive. Still, even with recombinant TSH, it's a several-day procedure. You inject, you get a scan, and then you have to have the patient evaluated, etc. In most clinics, use of scanning and treatment is with radioiodine 131. Therefore, that would preclude treatment because of stunning that may happen. In some clinics like ours, we use 123 iodine for diagnosis, and then for treatment, use radioiodine, so we don't have a stunning. But that is a problem. And then, of course, when you take patients off for several weeks off thyroid hormone, there is a potential that tumor may grow. So there are problems with whole body scanning. The recommendations for remnant ablation, as was mentioned also by Dr. AlZahrani, is that radioiodine treatment usually not necessary for most low-risk patients. For intermediate risk patients, we look at risk and benefit, and in most patients we treat. In high-risk patients, almost always radioiodine treatment is given for remnant ablation or for treatment. Here is a note that you should pay attention to. We ablate low or intermediate risk patients if post-op Tg is between 5 and 10. That means there is disease. Even if you can't see the disease, treatment with radioiodine somewhere between 50 and 150 millicuries would be recommended. And then conversely, if a patient is high risk and Tg is not detectable, but you suspect clinical disease, then radioiodine treatment and ablation is something that we consider. So what about Tg levels and remnant ablation? So here you can see again, Tg is very informative. If his Tg is low, remnant ablation in the majority would not be necessary. If Tg is somewhere between 2 and 10 or greater than 10, the likelihood of remnant ablation and outcome then progressively shrinks and becomes limited. And then finally, there is PET scanning. PET scanning is something that is available in almost all large medical centers in this country, outside this country, in Middle East, and in all parts of the world. Positron, emission, tomography, or PET. It uses 18F-FDG glucose analog. The glucose is uptaken by the cell but not metabolized. And it is a sensitive test, but it is also expensive. We use it in our patients when patient is Tg positive and scan negative. When we suspect in a patient who has thyroid cancer, and I see the patient with a Tg of 5 or 10 or 12, particularly increasing titer, we have done a CT scan of the chest, it was negative. We did an ultrasound of the neck. Then we did a radioiodine scan. All those tests are negative, so that patient is Tg positive, scan negative. The next step would be a PET scan, often useful. The alternative to PET scan is SPECT CT, single photon emission CT, or SPECT. It is nuclear imaging. It uses isotopes of different types, technetium or radioiodine. Its resolution and sensitivity is less than PET. Cost is less. Some centers use it instead of PET. But PET, if I have a choice, I would go with PET. So here is a patient that I saw with Tg positive, and we didn't know why. We did a scan, it was negative. Then we did a PET scan, and PET scan shows multiple areas. And in CT scanning, you see identified disease in the bone. Even bone scan was negative. And so the advantage of PET is that not only it identifies disease, but it tells you where, how many, and how big. Sometimes you can identify disease that is surgically treatable. Another patient with Tg positive and scan negative presented for further evaluation, and PET scan showed multiple areas of disease clearly identified here by PET. This is not something that is amenable to surgical treatment. There are multiple areas. This is not likely responsive to radioiodine, and this because there is no uptake. And so this patient is referred to our medical oncologist for chemotherapy. So recurrent thyroid cancer, when you look at a patient that has either persistent or recurrent disease, sometime after initial treatment, you want to decide, should I observe or should I treat? And so there are multiple issues that you want to look at prior to making a final recommendation. What is the risk associated with recurrent disease? I often see a patient that has 1 or 2 cervical lymph nodes. I often see a patient that has multiple tiny millimeter-sized pulmonary nodules. In those cases, there is no threat to function or quality of life or survival, and so many of those I may elect to follow. What is the impact of disease on mortality? If there is a 1 centimeter lesion in near the trachea or somewhere vital near a blood vessel, that may be very important. What is the risk of additional therapies, surgical treatment, or chemo, or radioiodine, or external beam? So you have to look at risk and benefit and see how that the formula helps the patient. And then what is the risk of observation? Like I said, if there is minimal cervical disease, I may elect to follow and see what happens. And so in the past several decades, management of patients with recurrent disease with papillary cancer has evolved. As Dr. AlZahrani also mentioned, in the early or late 20th century, between the 1950s and 2000, in the 5 decades, when I was trained and in my early practice, we used to be aggressive. We used to seek to destroy residual tissue. If there was lymph node, we would call the surgeon. If there was minimal uptake in the neck, we would give 200 millicuries of radioiodine. So there was aggressive treatment. I still see some of those patients that have side effects from treatments. So we were aggressively treated patients, and we noted that maybe there was no benefit. So in the past 2 decades, we try to identify clinical disease, find out if this is a significant recurrence, if this is reducing quality of life, if there is threat to this patient's survival and to good life. And so if not, we observe these patients. If yes, then we treat them with disease. Now, the new chemotherapies are tolerated, they are effective. Alcohol ablation is easy to do, effective for cervical recurrence. And there are other modalities such as laser treatment or RFA that can be applied to recurrent disease. So there are multiple areas that we have improved on in terms of our help for patients with recurrent significant disease. And so with that, I'd like to thank you for your attention. I'd like to thank the organizers for the invitation and hope to see you at a future meeting face-to-face. Thank you.
Thanks, Dr. Hossein and Dr. Ali. And now it is the time for question. The first question, Dr. Hossein. People, they just ask an indication for FNA less than 1 centimeter, that in people with microcarcinoma. And the second question, if this less than 1 centimeter micro PTC, tall cell or columnar, does it change the management or no?
The answer is definitely, yeah. If it is papillary cancer that is microcarcinoma with tall cell variant, let's say you have already performed lobectomy for this patient. If this is tall cell variant, if there is no outside involvement, no lymph nodes, ultrasound is negative, and post-op Tg is low or detectable but low, I think that I would still follow that patient. Papillary microcarcinoma that is resected but is tall cell is a little bit more aggressive, but once you have done the treatment, there is a follow-up, careful follow-up is appropriate. when you do biopsy and you want to papillary cancer and you want to elect medical management, you don't know whether this is Tolson variant or not. So that doesn't. So in that sense, I am limited. If I recommend observation, I don't know whether this is Tolson variant. Molecular genetic testing is not commonly performed on tumors, so we don't know. But even BRAF doesn't really give you indication for aggressiveness. So even if we have genetic testing and we do BRAF, and if it is positive, I'm not sure if that would tell me that this patient with positive BRAF will do worse in future. And so I say, let's not do medical management for this. That I don't have an answer for that. Okay. The information is limited.
Yeah. Okay. Dr. Ali, there is a question. 50-year-old lady with right lobe PTC treated with total thyroidectomy and 5 lymph node positive, and she received radioactivity and 150. What are the chances of recurrence and what's her prognosis?
So, okay, so this is, what is the size of the tumor? Did they mention it? Or
actually, they didn't mention, but not mentioned, just only right PTC.
Okay. All right. So a patient with the papillary, let's assume it's conventional papillary thyroid cancer. Let's assume that the tumor was 3 centimeters. There is 5 lymph nodes of small to moderate size. So if we are going to stage this patient according to ATA staging, she's going to be in the intermediate risk group, unless the metastases are very small. But here we are assuming the lymph node metastasis is more than 2 millimeters. And that means if it is conventional histology, that means the recurrence is in the range of around 5 to 10% recurrence. Mortality is quite low. So, and I think it's more important here, and this is a chance for me to emphasize one more time the point. It probably doesn't matter much what was the initial features. What would be more informative is what is the situation today. So let's say this patient comes to you today and her Tg is 50 on thyroxine. Although her initial features are not that aggressive, this patient is harboring a disease. She is carrying a disease somewhere, and especially assuming this 50 is on thyroxine, this patient must have significant disease somewhere. And this is basically what I'm saying here is the dynamic risk stratification. She was low to intermediate risk, but today she's coming to you. She has biochemically incomplete disease. And you need to do further imaging, and you may actually discover structural disease. So again, I think the assessment should be done whenever the patient comes to you. But with the features you have given us, her chance is only around 5 to 10% of recurrence, taking the limited information alone given.
Okay, there is a few questions about how we'd like to determine the indeterminate response in ultrasound finding.
Is that for me?
Yes.
Okay. So let me give it. So indeterminate response, basically, if I want to translate it in let's say common language, it means basically that there are some features we are not sure if it is benign or residual cancer. As mentioned in the slide, I cannot be confident that this patient is free of the disease. So what would be the situation? So it has been defined actually in the ATA guidelines as follows. Tg between 0.2 to 1 on thyroxine or 1 to 10 of thyroxine stimulated. So stimulated between 1 to 10 or suppressed between 0.2 to 1. This is a mild elevation in thyroglobulin that we are not sure what the significance of it is. Second, Tg antibody elevated. So it makes your Tg useless, more or less. And therefore, you're not confident if the patient is free of the disease or not. Third scenario. You send the patient for ultrasound, and the ultrasonographer reported some lymph nodes that are not totally reactive or benign looking, but at the same time, they are not highly suspicious. And you did not want to pursue FNA, and basically these three scenarios are common scenarios in our practice when you say, okay, I'm not absolutely sure that the patient is free of the disease. He's not in excellent response, but at the same time, he is low risk. He probably or she probably does not have a disease, or if she or he has a disease, it's low risk and it is a small volume disease. I will follow this patient see. And as I mentioned to you in the study that I presented, out of 125 patients that we found to have indeterminate response after 12 months, roughly, most of them actually, they achieved excellent response over time. So most of those patients with low thyroglobulin over time, they go to a situation of undetectable thyroglobulin, undetectable Tg antibody, and nothing to worry about. So indeterminate response, in general, the prognosis is excellent. Maybe Dr. Gharib can elaborate further.
No, I agree. I agree. That's our practice is similar to yours.
Okay. Dr. Gharib, question, is follow-up with TGs helpful in people with lobectomy in thyroid cancer compared to that just hemithyroidectomy?
So TG, no, TG is a measurement for disease. If TG is 0, we are very comfortable that there is no disease, no thyroid cancer, either persistent or recurrent. And if the TG, as was mentioned, 50, then highly likely something bad is happening. So with lobectomy, partial thyroidectomy, TG will be measurable. We understand that. The question is, what happens to the levels in follow-up? So if a patient has partial thyroidectomy and TG level is 5 or 8 or 12, that is expected. We follow that person every 6 months, and if TG trend increases, then that is suspect. Then we embark on an evaluation to see if disease is recurrent or persistent or where is it coming from. On the other hand, if TG is 7 or 12 and stays stable through a period of months or several years of follow-up, that is stable disease, that is stable TG, does not necessarily reflect disease. It is probably TG coming from the remaining normal functioning thyroid tissue, and we would ignore that. And we usually do thyroid ultrasound on these patients anyway, so we are monitoring carefully. But TG doesn't worry me at that time. Just the fact that it is.
Another question, Dr. Gharib. We would like to check TG as well as imaging, ultrasound / whole body scan after treatment with radioactive iodine and thyroidectomy people with low to moderate risk. Like when you want to check and for how?
So our current practice, which I think is probably true elsewhere, is that we see patients after thyroidectomy 3 to 6 months for an office visit, for TG measurement, for TSH measurement, and if it is 6 months post-op, we also do an ultrasound. Now, in patients that we think would need radioiodine remnant ablation, which is mostly in the intermediate or high-risk patients, those patients, we bring them back within 3 months. Now, the reason we bring them back in 3 months is because of logistics. In your practice, they may come back 6 weeks because they are in your area. Our patients are referred, therefore, because of logistics, we bring them back in 3 months. We scan them, and if necessary, we treat them. The treatment dose, usually we go from 30 to 150, depending on risk and specifics of the case. Usually in our practice, our surgeons do such a complete job that often there is no remnant activity and patient requires no radioiodine, even if they are intermediate or high risk. If there is no disease present and Tg is less than 1, we give no radioiodine treatment. On the other hand, if the patient comes back in 3 months and we do a scan and there is remnant and Tg is 3 or 4 or 2, then this patient with intermediate risk will receive somewhere between 30 and 100, usually around 50 millicuries dismissed for follow-up. Did I answer your question?
Yes. Dr. Ali, just a question. What's the optimal TSH suppression in a young lady, 29-year-old female, PTC, and 2 centimeter with lymph node metastasis? Her Tg is undetectable. What's the optimal TSH suppression for this patient?
So again, we go back to the same thing. What is her risk? Ask yourself, if you're in the clinic, what is her risk of having a recurrence? This is a patient is in excellent response. She is also perimenopausal. And therefore, I would be very comfortable with this patient, especially if she had the disease for a couple of years or a few years before. I'll be happy to have her TSH in the lower range of normal rather than suppressing her because she's already more or less cured and she's also having another factor in her history being perimenopausal. I don't want to induce any bone loss. Therefore, I am so comfortable with the 0.5 to maybe around 2. I would like to see between 0.5 to 1, but I would not bother too much if it is 1.5 or even 2. If she has no features of possible recurrence. I mean, the patient you described now is a patient is in excellent response. Tg is undetectable, Tg antibody is negative, ultrasound is negative. Her disease to start with was not aggressive. Therefore, I'm very comfortable with this level. I don't know what Dr. Gharib.
I agree 100%.
Thank you so much.
Okay, Dr. Gharib, a patient with low risk thyroid cancer and in the first trimester, would you like to delay further her surgery till the after delivery? Low risk patient.
Oh, definitely. First of all, let's backtrack. If I see a patient who's pregnant, second trimester or third trimester with a thyroid nodule, and even if that thyroid nodule described by ultrasound as high suspicion, I wouldn't do biopsy because I don't want to do surgery. So I would just watch and follow and decide on biopsy and treatment postpartum. But if I'm asked for a consultation in a patient who is 7 months pregnant, who had ultrasound and who had biopsy, and it is papillary, I still say wait and follow. And there is hard to tell. I mean, how do you tell the patient is high risk or low risk? It may be a 2 centimeter lesion. There may be a couple of lymph nodes there that are suspicious. I still consider that acceptable to be dealt with postpartum, not risk anything during the last trimester of pregnancy.
Dr. Ali, patient with 2 centimeter thyroid cancer with diffuse sclerosing, do you offer them radioactive iodine treatment or therapy?
We just had one this morning, 23-year-old lady pregnant, and this actually relates to the previous question. So we had a discussion on a patient who's 23-year-old who had thyroid cancer, diffuse sclerosing type with extensive lymph nodes. And the question came again whether she should be operated during pregnancy or not. My practice with pregnancy is if I catch them in the first trimester, or any trimester, but especially in the first trimester, I don't, of course, based on studies, I think maybe the main one is the retrospective study of Dr. Mazafiri and Dr. Musa. I don't send them for surgery, but I definitely like to see them within 2-3 months, and preferably with an ultrasound the second trimester, just to make sure that they're stable. Most of them, they do well, they remain stable, but occasionally you can see patients progressing during pregnancy, and the best time is the second trimester to operate on them. So that's just coincidentally, we had a patient like this morning, and she has diffuse sclerosing type. Yeah, diffuse sclerosing type is common, especially in young patients, especially in children, and is frequently associated with extensive lymph node metastasis. However, I think the final outcome of it is not much different from the other types of thyroid cancer, especially conventional. Yes, I give them radioactive iodine because frequently they have lateral lymph node metastasis, and it's not uncommon, especially in children, to have lung metastasis. I think in total, in total, diffuse sclerosing type tend to be aggressive, and radioactive iodine is recommended, at least in my practice, for most of them, because most of them will have lymph node metastasis. If, on the other hand, it's diffuse sclerosing type, but totally intrathyroidal, there is no lymph node metastasis, the Tg is very low post-operatively, I may not give them radioactive. But for most part, most of them, they will not have this picture. They will have more aggressive picture with lymph node metastasis, and they need radioactive iodine.
May I add one thing? I agree 100%. I think that the conclusion from our talks, both of us, is that there are some patients that have thyroid cancer. They are low risk. We offer them no treatment or minimal. But then at the other end, there are patients with thyroid cancer that, like this one you described, diffuse sclerosis, of course, surgery, of course, node dissection, of course, remnant ablation, tall cell variant. So I think that we are learning more to offer less or more aggressive treatment to subclassification of these patients. And that's the art of the practice, and that is the advancement in the algorithms of treatment.
Yeah, thanks. Question, Dr. Gharib. Just a few about your experience in ethanol injection for people with recurrence local lymph node. What's the good candidate patient, and what's your experience in that?
So the experience overall very positive. It is very minimally invasive. It is well tolerated by patients. Our radiologists, there's a group of them, 6 or 8, but there are 1 or 2 of them who have had 25 years of experience. And so I specifically asked for the one that I have worked with, and results are very good. Patients tolerate treatment. Results have been excellent. I've had probably 25, 30 patients through the past 2 decades that I have followed. In a few, results were not happy. Disease came back, more lymph nodes, surgical treatment. Eventually, 1 or 2 of them died. They had bad disease. But in the majority, I would say 80-85% results have been very good. They have 1 or 2 lymph nodes. We inject alcohol. Patients have, in our clinic, they get 2 injections. Today and 1 tomorrow. They go home, they come back in 6 months. We follow them every 6 months for a couple of years, and then yearly thereafter. Results are usually very good. Some of these nodules stay the same. Majority shrink. Infrequently, they disappear. A 2-centimeter nodule disappears completely after alcohol injection. So I would summarize and say that if disease is recurrent in the neck, and there is 1 or 2 lymph nodes, this can be easily treated, and preferably should be treated with alcohol ablation. That results are very good, and that I would encourage clinics to learn and offer this to patients with recurrent thyroid cancer.
Okay, thanks, Dr. Gharib. Maybe just last question for Dr. Gharib and Dr. Ali. For Dr. Ali, there is last question. How do you manage patients who cannot tolerate high doses or maximum doses of thyroxine required to attain TSH on target?
So if there is evidence of, let's say, residual disease, or the patient has an indeterminate response or biochemically incomplete, then or structurally incomplete, obviously, then those patients benefit for the most part from TSH suppression. Now, if the patient cannot tolerate that, one thing that helps, all the studies on all of this is combining this with a small dose of beta blockers can help those patients. So sometimes we, especially if they have another indication for beta blocker, let's say he's hypertensive. If not, then of course you don't want to induce a chronic morbidity, and the patient quality of life is disturbed. So therefore, you decrease it to the dose that he will or she will tolerate. So I don't want the patient to be sick. I must say, this is my personal view. The issue of TSH suppression has gone through many stages and controversy. And there are studies supporting it, and there are studies not seeing much of benefit. I'm not a big believer in TSH suppression, except for patients who has a disease, a definite disease. But for patients, just giving them, suppressing them with just to prevent a disease, or because they initially had some aggressive features, but today they are in excellent response, I don't really think. I think the benefit versus risk is not in favor. So for a patient who has no disease or no evidence of disease, and that's basically excellent response or even indeterminate response, I'm not so adamant and eager on TSH suppression. For patients who have a disease, I would like to see them suppressed, but if they cannot tolerate it, or they are going to endure significant side effects, then I would rather decrease it to the maximum they can tolerate.
Okay, thanks, Dr. Ali. Dr. Hossein, last question. 8-year-old girl who has thyroid cancer as well as lymph node metastasis. How would you like to give her radioactive iodine?
8-year-old?
8 years old, pediatric, yes.
8 years old.
Yes.
So the first thing you want to remember is that in children, at least in what we see here, they do well. Disease is usually extensive, lymph nodes. Sometimes they even have pulmonary metastasis at diagnosis. We try not to be very aggressive. So we do, yes, we do remnant ablation if there are if there are many lymph nodes or there is distant disease present. If disease is limited to the neck, no evidence of distant metastasis, I would say maybe even remnant ablation not necessary. So you have to look at it, understanding that children with disease do well in long-term follow-up. No matter what you do for them, they usually have extensive disease, and they can outlive normally their disease. And so in this case, 8-year-old, I would say, okay, with thyroidectomy, you need node dissection, yes. If that is the extent of the disease, follow. You may not even need remnant ablation. On the other hand, if there is extensive lymph node disease in the neck, or there is any suggestion of something in the lungs, then I would say remnant ablation with a larger dose may be indicated, but I would not be very aggressive with extra radioiodine doses or extensive surgical management.
Can I add a little bit of this, because this is an interesting subject? As
yes, sure.
Yeah, as Dr. Gharib mentioned, those patients, the children, I have quite some experience with pediatric thyroid cancer. They come with the aggressive features, but they do well. We actually reported our experience with around 100 pediatric patients a couple of years ago in JCM. And the bottom line, Yes, they have aggressive disease. They are more likely to have distant metastasis. And I think in my practice, the ones that I give them radioactive iodine, the ones with distant metastasis, definitely, or with extensive lymph node metastasis. But for a patient who has few lymph nodes are in the central compartment, and I don't usually give them the children. I'm talking about the children. There was also a recent article that I reviewed and published in JCAM for the extensive experience of MD Anderson, 73-year experience with pediatric cancer, 73, and since 1940. And I think they had some around 200 children with, and again, over this 73-year year, out of around 200, only 11 patients died from thyroid cancer. So this, in children, they have aggressive disease, but they don't die from it. They do very well, and they respond even better to radioactive iodine than adults in general.
Yes. That's the key. That's the take-home message.
Yeah.
Exactly.
Okay.
Thank you.
I would like to thank Prof. Hossein Gharib and Professor AlZahrani. It is very informative. I receive a lot of appreciation and letter from this presentation. And I would like to thank also all attendees. I apologize, maybe some question we didn't answer, but we are running short of time. I would like also to thank GAED, and be reminded to fill the feedback, and you will receive your certificate. Thank you.
Thank you very much. I just want to mention that provide my email to the attendees. If there are questions unanswered at this meeting, they can contact either of us. We'll be happy to reply. And Dr. Ali, good to see you, my friend.
Actually,
God be with you both.
Thank you so much,
this
Dr.
is a kind of
Thank you very much,
and
Dr.
we are
Naji.
very thankful for both of you.
Okay, very good.
Okay,
thank you, Dr. Naji. Thank you very much for moderating and for helping the session.